balloon today. We've already assessed, that we've used it once, and I'd like to hear more about that, but we can wait until we get through the in-service and then kind of talk about what happened when you used it and if it ended up working and all of the particulars of that as well. So at any point you have any questions, just let me know, because this is meant to be interactive. So if something I say doesn't make sense or you want clarification, just let me know. Okay, so it comes in a box. So for those of you that have used it before, you'll recognize this. For those that haven't, it looks like this. It comes one to a box. And so once you open this, and these do have a 3-year shelf life, I always like to let people know. When you open the box, there's going to be a sterile sleeve containing the kit that holds the Bakri. And then the other thing that's very important that most people overlook is the instructions for use, or IFU, what we call it. This is really helpful, particularly if a provider has never used the product before and is wondering, is this the patient that I need to put it in? What are the contraindications? This little booklet's a lifesaver, so I always tell people about it. We'll talk about the important part. It's in about 20 languages. The first one is English. That's the only one that people ever look at. So as I was mentioning to Debbie before, there's actually 2 versions of this kit in circulation. One that you're currently using that has 2 things in it. It's got a syringe and a catheter. And then there's the kit that I'm going to show you here. We're going to talk through both, but this is actually our new kit, and this is the only one that's going to be available after June of this year. So I want to make sure you feel good with either version because you just ordered one of the other ones. So basically, to start with, we'll open the sterile sleeve, and as it would be on the unit today, the kit would look like this. So you essentially have 2 pieces that we talked about before, the catheter and the syringe. Mm-hmm. That's it. So to get into the nuts and bolts of it, the catheter is obviously the part that's going to be doing the tamponade to stop the bleeding. This is an all silicone catheter, so there's no latex in this. Now if we start here at the end closest to the provider, the Bakri is always placed by a physician or a midwife. Okay, so no one should ever be asked to place this into a patient. So 2 ports here. One has a blue stopcock on it. This is simply to hold fluid in the balloon and allow fluid to come out after the 24 hours is up. Second port is open-ended. So this has 2 functions. One is to accept a urometer or a Foley bag. So that's where you're actually going to be collecting the blood loss that's happening through the inner lumen of this catheter. The second function of this open port is to allow for flushing. So if the provider thinks that there are clots that are obstructing the 2 holes on either side of the tip of the catheter, they can actually take the Foley bag off, take a syringe. A 60 cc syringe works nicely. They can affix it here and flush through that lumen, so to clear any obstruction at the tip. Then we've got the balloon. The balloon itself will hold up to 500 milliliters of fluid. So one nice thing to kind of do is to have that quantity of fluid on hand when you grab the product. As we'll talk about in the new kit that comes with IV tubing, you'll want to have a 500 cc bag of fluid handy, because that way the physician cannot overinflate the device. The last thing is 2 holes on either side of the tip, and that's strictly to let the blood flow from the uterus out into your bag that you're going to be collecting it in. Any questions about the catheter? Yes?
Do you have to have a bag attached to that end?
No.
Okay.
So as it stands now, we'll talk about how you inflate it, but what it is it's going to be kind of like a water brigade. So you'll take the syringe, ideally you grab a second syringe too, because it keeps it going faster. But what you would do is you'd basically pour fluid into a basin, you'd aspirate up 60 cc's, you'd hand it to them, they're going to affix it here to the catheter, they're going to instill that fluid, and then very importantly they're going to turn the stopcock to hold the fluid in, and then swap out with the next syringe, so on and so forth, until they have whatever volume into the balloon that they want.
Fire brigade is a good term there, because that's kind of, yeah.
That's how it was.
Well, yeah, but not knowing that that's what it needed to be, yeah.
Right.
Yeah.
So that's what's going on with this version, but we'll talk about the differences between the 2. Okay, so you should have one of these on the unit now, which you may not have had at the time that you use this. This is very valuable. This is like gold. So What I tell people to do when they grab the Bakri box, they should grab the poster as well, because this can go in the room. It's laminated for a reason, so you can wipe it down afterwards, but definitely grab it because it walks through everything that I'm going to tell you today. So that way you don't have to commit any of this to memory. Just take the poster. The things outlined in a box are the most important things, but it will give you all the need to know items. So always grab the poster. You would also need to grab the Foley bag or the urometer to collect the blood. And then eventually with this kit, you would need to grab the 500cc bag of fluid. Is that clear to everybody? Okay, so we'll go through the poster. Only the first 3 steps here are really for the physician. It's for their edification that they go through these 3. I cover them in every in-service, even with nursing staff, because let's face it, you guys are here doing the continuing ed and the physicians may not go through this. So it's very imperative that you know about it and how to use it. So number 1, evaluating the patient. This is a conservative management tool for a postpartum hemorrhage. So what does that mean? So step 1, you're going to be massaging the fundus, trying to get the uterus to tone down. Second step is going to be the administration of uterotonic drugs, whatever that may be here in your unit. The third step is a balloon tamponade device. So that is kind of the order and how things should fall when you have a patient that's having a PPH. Now beyond that is what we're trying to prevent with the device, and that would be either embolization or the need for a hysterectomy. That's the ultimate thing that we want to prevent with the Bakri. So step 1, evaluating the patient. So we've gone through the first 2 things. The physician says we're going to use the Bakri. Again, this is when, if they're not sure, they look at the instructions for use in the box. If there's any question, there's 7 contraindications that are listed on the 3rd page of this booklet. So I always have them in question to look at it. You can access this without breaking the sterile seal, so there's no reason they can't just open the box and look. So I always let people know about that. It's very handy. In addition to the poster, it's probably the most important thing to have in the room. So they're going to determine it's the proper patient. Second step is to determine that uterine volume. So with the kit that you have now, the reason we say this is because we know that this is a high stress moment. We don't want the physician having to keep track of how many syringes they've put into the balloon. So we say determine a volume up front and have nursing staff pour that over into a basin, so that way they know when I have emptied that basin, I have instilled X volume of fluid. So on average, 300 milliliters will stop a postpartum hemorrhage. So I always let people know that. So 300 is the average. The balloon does go up to 500. So not every patient's going to need the full volume. Lots of variables there. How close to delivery, how large was the baby that she delivered, or plural. So all of those, again, are going to be a doctor's judgment call, but I always tell nursing staff 300 is the average. Okay, so that's something to commit to memory. It does say on here 500 milliliters though. It also says on here to get an abdominal ultrasound to determine that volume. We know that's not going to happen, okay? So we just have to say it, but 300 is the average. So if you're ever wondering and reading this closely and you're like, whoa, what's that? That's what the clarification is. Inserting the balloon. Okay, very important. There's 2 ways to place this device. Okay, so if this happens here on the unit, it's going to be placed transvaginally. Now, if it happens in the OR after a C-section, it could still be placed transvaginally if she's closed, but you also have the option to go through the hysterotomy while she's still open. So those are the 2 options. We'll talk through transvaginal placement first because that's probably going to be the more frequently occurring scenario. So what they're going to need to do is they're going to need to choke up on the balloon with either their fingers or a ring forceps, some way to give this some rigidity. If they start grasping back here and trying to get through the cervix, it's not going to happen. So definitely tell them, they're going to be sterilely prepped. They're going to have their sterile gloves on. So they need to choke up on this and advance this through the cervix. Like I said, they can use a ring forceps if they would prefer that. Now, if my hand is the fundus of the uterus, ideally what they're going to do is they're going to advance this through the cervix and they're going to get the tip of the catheter as close to the fundus as they can. Now, they may not be able to touch it, but the closer that they can get to the fundus, the better. What we don't want to have happen is them to just barely get it past the internal os and then start inflating. For a couple of reasons, but one, if you look at this deflated, you can see that it's kind of cylindrical. So if they just barely get it into the uterus and it's resting on the os, when they start inflating it, it's going to want to dislodge through the cervix, and then you're not going to get a tight seal. You're not going to be able to get that good tamponade on the lower uterine segment once it's inflated, and the patient's going to be very uncomfortable. So very important to advance it as far as they can into the uterus. They don't need to worry about perfing the uterus because this is very flexible. If it gets up against it, it's just going to deform in. Okay, so the further that they can get it in, the better. Now, once they've advanced it, they feel sufficiently certain that this is past the cervix. Wherever that is externally, they're going to want to hold it. Okay, this is very important for a couple of reasons. One, we've worked hard to get it in, and we don't want it to slip back once we start inflating it. Now, this is one that has 500 in it. I'm going to let you all hold this, pass it around. You can feel that it has weight to it. So if they start inflating it, it's going to want to dislodge. So we hold it to prevent that from happening. The other thing is we don't want this to fall on the floor. Keep in mind she's just delivered and she's open. So if they don't hold it, the worst case scenario is it's going to fall onto the floor, and then they're going to have to get another one out because our sterility has been compromised. So that's why this is a very important step. And I encourage people to hold it throughout the inflation process. So whether that's you holding it or the physician's holding it, someone just needs to keep a hold on it. Any questions on that? Okay, so that's transvaginal placement. Now, if we go through the hysterotomy, what we recommend is that they take the port sides first and go through the incision, and someone will get below the drape to pull this through the vagina. The reason that we say that is because this is going from a clean to a dirty versus going dirty to clean. So that's why we recommend it. If they're concerned about passing the stopcock through the cervix, particularly if she didn't fail induction, so she's completely closed, the stopcock is connected by a Luer lock connection. So they can actually take this off. It makes this a little bit easier to pass through. If they need to lubricate it, they can. The only word of caution on this is that anything that comes off does need to go back on, because this is the only way to keep that fluid in the balloon. So if they do that, make sure that they reconnect it after it comes through the cervix. Then they'll need to suture the uterus and then inflate the balloon. As you all saw, it's a giant water balloon once it's in. So what we don't want to have happen is them to inflate first and then throw a suture through the balloon, because then they've punctured it. So any questions either way, OR or L&D suite? Okay. All right, so step 4 on the poster here is filling the balloon with sterile fluid. We don't specify what fluid that is, but it just needs to be a sterile fluid of some nature. Air or gas should never go into the balloon, because obviously if that balloon were to rupture, then we're going to be introducing potential emboli into their system. So we don't want that. So it should always be sterile fluid. So filling it up. This sounds like maybe where it was difficult when you use this. But how this will work, so if we're back to holding it here, we'll imagine this is in the uterus. Like I mentioned, you get one syringe that comes with it. It's nice to grab a second one, make it a 60, that's probably the easiest. And then what will happen is we had already predetermined how much we were going to put in, that we have in a basin. But go to the basin, you'll inflate or aspirate that volume into the syringe. Then what they'll do is connect it here to the stopcock port. Out of the kit, the stopcock is always open, so they don't need to turn it to allow the fluid to go in, it's already ready. So at that point, then they'll push in the fluid into the balloon, then they'll turn the stopcock and disengage the syringe, and they'll continue to do that.
I've got a question.
Sure.
Okay, I've got somebody over here now pulling up fluid, passing it to the physician who is got one hand holding this, the other hand is trying to maneuver the stopcock and get the syringe on. You need 3 hands.
Yeah, ideally you would, or the nurse can be holding it as well.
But she can't because she's pulling up.
So it's just going to determine, it's going to be
So
determined.
you need that second nurse in there.
Ideally you would have 3, ideally. You know, if you can't have 3 and you only have 2, then someone's just going to have to, you know,